Interventions in these situations are varied. The first Harritzoff decision directed the clinician to warn the identified victim based on the initial case. That was later modified to oblige the clinician to take steps to protect the identified victim. Warning the identified victim can be effective and is the first possible step. In my experience, it's not been unusual for the victim to know that they have been threatened. The next step is that can be taken is to call the local police, explain the situation to them, and recommend that they make an assessment and probably have the person evaluated by a mental health professional, typically in an emergency room. The police will probably take steps to see the person of concern, but they will do their own assessment, and they may make the decision that they cannot take the person into protective custody to insist on a evaluation in an emergency room. That is their decision to contact the local police department. If the person agrees, hospitalization can be a very effective step to protect the identified victim. If the person has been treated for depression or psychosis, goes to the hospital and gets better, the thoughts of doing harm to others or self often abate, and there's no need to do anything further. If the person declines hospitalization, the clinician may be obliged to follow the usual rules to try to effect an involuntary hospitalization. That can be hard in a private office, and enlisting the help of the police is probably needed at that point. The clinician may decide to try to enlist the help of the family, but that can be questionable. The family often has no mental health training. They can be very conflicted to take steps to protect a relative from potential harm by another relative. If it is the father who's been expressing dangerous thoughts to harm the mother, which may occur in an older couple, what does one do to protect mother and control the father? Relying on family to take care of the situation and prevent harm is questionable. Finally, the most important and easiest thing to do is to consult with a peer. This can be a person another mental health provider who is experienced and has probably dealt with these issues. A clinician can also contact the local law enforcement agency, try to make contact with a police officer who is aware of what these situations involve and what possible steps there are. Larger departments may have access to a mental health consultant. Other potential sources of consultation are an attorney, particularly one who is aware of mental health and medical issues. Another resource is the Maine Medical Association. Andrew McLean, the CEO, has expertise in this area. This is a very important issue. The clinician is going to be often conflicted and anxious about intervening. Rationales to avoid may include the clinician thinking, well, this is a rare event. What do I do? I'm alone with this problem. There are strong psychological forces to avoid dealing with the problem. Getting involved can take substantial time, which can be difficult with a busy schedule. A major conflict is the issue of confidentiality. Clinicians may have very high concern for confidentiality and maintaining that. This is a situation that mandates breaching confidentiality, at least potentially so. In actual practice, violating confidentiality is of a concern. Confidentiality is stressed in the ethics of various professions, medically and mental health professions. But the clinician needs to ask himself or herself about the risk of not intervening versus the risk of violating confidentiality. In many years of forensic and clinical practice, violations of confidentiality have been a minimal problem. When they have come up, they've been treated lightly by the courts, in my experience. On the other hand, the risk of not intervening if a bad outcome occurs, either harm to others or suicide or both, is serious. Although harming others and suicidality may be relatively rare events, the outcome is so tragic that it is far outweighs the risk of violating confidentiality. Concerns about violating confidentiality can be mitigated, and the statute specifically absolves the clinician from responsibility for violating confidentiality if done in good faith. Documentation of risks, what the clinician has done to assess risks and options will go a long way to protecting the clinician from any adverse legal consequences of violating confidentiality in these issues. There are other issues that mandate breaking confidentiality, such as some infectious diseases and child abuse. Finally, the clinician may be concerned for personal safety. If that is the case, the clinician is absolved from having to take steps to warn or protect the potential victim that is specifically addressed in the LD 287. Risk to property is not specifically addressed in the statute, but can be a reason to be concerned for issues of violence. There was a case in Vermont in which a patient expressed clear intent to burn down his parents' barn. A clinician did nothing, and the young man burned the barn down. The clinician was held responsible for not giving the parents a warning. Serious property damage, such as arson, probably warrants taking steps to protect or warn. This case was selected to demonstrate several points that have been covered in the discussion. First, this young male is in the higher risk group. He's unemployed. He's being left. He has prior problems with being angry, and he's been assaulted with his girlfriend, including in ways that raise a great deal of concern. Prevented her from calling for help by taking her phone. He had thoughts of strangling her, which is particularly worrisome. His life is in shambles. He has a history of depression, aggressive behaviors, and substance use. He has access to a firearm. His girlfriend has also had problems and may have difficulty setting limits and acting in her own best self-interest.